Professor Mohsen Mukhtar, who will present to us today a very interesting talk about sequencing anti-HER2 treatment in metastatic breast cancer.
Okay, thank you, Mr. Chairman, and I'd like to thank the organizing committee and Hisham Al-Ghazali for inviting me to be part of this very nice symposium and conference. I've got the very difficult challenge on following on two great speakers, Dr. Ahmed and Dr. Nuhad, and talking about anti-HER2 therapy in metastatic breast cancer. But what I'll be trying to do is going through sequencing and trying to figure out which patient exactly do we need what therapy for. So I'll not go through what we all know by now from the past two lectures on what therapies we do have, but I think what we do have to ask ourselves are several questions. Before we start treating any patient, has this patient ever received trastuzumab? And has this patient, if she's received trastuzumab for metastatic breast cancer, has she rapidly progressed on it, or is there a gap? One of the other questions, is there a brain mets? What toxicities has this patient carried on, either from the adjuvant to neoadjuvant therapy or for the metastatic therapy? Do we need rapid response for this patient? Is the patient, as well as being HER2 positive, also hormone sensitive or ER positive? And is this first, second, or even third line therapy for these patients? Now, going through what we know in the first line therapy, well, we know from very early data that trastuzumab does work, whether it's combined with either taxane, whether with paclitaxel or docetaxel. It did give you an overall survival benefit that was statistically significant in favor of the combination. And we know that adding on a second chemotherapy, such as carboplatin with paclitaxel, did add on in terms of overall response rate, as well as progression-free survival, that were both statistically significant in favor of the combination chemotherapy rather than a single agent. This did not turn out as overall survival benefit, but probably because of the further lines that the patient was allowed to receive. Then we had a very interesting trial, the MA31 trial. This was a trial where patients were allowed to have received either neoadjuvant or adjuvant trastuzumab and chemotherapy for breast cancer, and the patient had to be free for more than 12 months. And the patients were randomized either to lapatinib taxane, followed by lapatinib as a maintenance, or trastuzumab taxane, followed by trastuzumab as a maintenance. And they had 536 HER2 positive patients. And if you look at the data from this, we can see clearly that still trastuzumab does give you a better terms in progression-free survival. That was, as you can see, nearly 4.7 months, and a hazard ratio overall benefit of around 48% for these patients. Then we had the famous Cleopatra trial that was just presented. I'm not going through much of the Cleopatra trial, but what I wanted to show you is the profile of these patients. These patients had to have had a disease-free survival that was more than 12 months to enter into this trial. So they were allowed trastuzumab either in the neoadjuvant or the adjuvant setting, but they had to have had a disease-free survival more than 12 months. They also had to have left ventricular ejection fraction that was more than 50%. And we can see clear-cut benefit for progression-free survival, as well as looking at this second interim analysis of the overall survival. The 3-year estimate, you can see a 16% benefit for the dual combination rather than the single agent. And what also comes out from this trial is that we've probably hit the 3-year landmark for overall survival for metastatic disease, and this you can see from the single agent of trastuzumab plus taxane. Now, the other question, is this patient also hormone sensitive as well as being HER2 positive? And we've got several phase 3 trials. The two most important, I think, are the Tandem trial, and this was anastrozole versus anastrozole plus trastuzumab in patients who are HER2 positive as well as being ER positive. And you can see that there is, in terms of progression-free survival, you can see doubling of the progression-free survival for these patients. And if you look at increase in the median overall survival, that was not statistically significant, but coming out of this, again, you see that we have more than 2 years overall survival for this combination. Looking at the second trial, and this was letrozole lapatinib, and this was a trial of combination with versus single agent of or anti-aromatase inhibitor, a large trial that showed you that there was a progression-free survival. The first analysis was a progression-free survival of 8.2, and after a follow-up of 2 years, you can see that this progression-free survival has increased to 11.9 months for the combination therapy. And also, what's important from this is that the clinical benefit rate for these patients was 48%. So it is something that you can really consider when you do have a patient that is ER positive as well as being HER2 positive. So if we put all these in summary, what can we use in first line? Well, if your patient has not had neoadjuvant trastuzumab or adjuvant trastuzumab, you can go on for trastuzumab plus taxane or the TCH coming out of this trial. If your patient has had neoadjuvant and adjuvant trastuzumab, you can see that we can go on for the combination of or dual anti-HER2 therapy. This will give you the best overall response rate, reaching up to 82%, and the progression-free survival that is more than 18 months or 1.5 years. Now, if your patient is not in need for rapid response rate, and if the patient is also hormone sensitive, you can use, if the patient has not received neoadjuvant trastuzumab or adjuvant trastuzumab, you can go on for anastrozole trastuzumab. This will give you an overall response rate of around 20% with a progression-free survival of around 5 months and an overall survival that is more than 2 years. And if you look at the patient having had or received neoadjuvant or adjuvant trastuzumab, then the combination of letrozole plus lapatinib is the choice for these patients. Going on to subsequent lines of therapy, we had the JBG trial. This was trastuzumab plus capecitabine, and these patients were progressing under trastuzumab. So this is subsequent lines for patients who've received trastuzumab in the metastatic setting, and you can see from this trial capecitabine versus the continuation of the anti-HER2 therapy, and you can see response rate is nearly doubled and statistically significant. Time to tumor progression also has increased from 5.6 to 8.2 months, and an overall survival benefit of around 5 months. Again, not statistically significant, but probably because of the further therapies. This has also been tested out with lapatinib, and lapatinib was tested out versus capecitabine or lapatinib capecitabine versus single agent chemotherapy or capecitabine, and you can see time to tumor progression again was increased from 18.6 to 31 weeks, overall survival 71 weeks versus 56 weeks, and an overall response rate of around 23% for these patients. What came out also from this trial was that it showed that giving lapatinib in this setting did decrease progression in the brain mets as first site of progression. Then we had the combination of lapatinib plus trastuzumab. This was tested in the EGF trial here, and the primary endpoint of this trial was progression-free survival. You can see that the combination or dual anti-HER2 therapy does add on in terms of progression-free survival as well as in terms of overall survival that were both statistically significant. Surprisingly, the overall response rate in this trial did not show much benefit. Then we had the TDM1 trial or the Emilia trial. This was TDM1 versus lapatinib plus capecitabine. Again, Dr. Ahmed has gone through this thoroughly, and you can see that TDM1 does do better than the lapatinib capecitabine combination. The second interim analysis of the overall survival from this trial, you can see 30.9 versus 25.1 months in terms of overall survival. That was statistically significant in favor of the TDM1. Then the Bolero 3 with everolimus. This was an addition to vinrolbine plus trastuzumab, and these patients again had to have had progression on trastuzumab during treatment. Looking at the primary endpoint, progression-free survival, this was met, but not much. As you can see here, 7 versus 5.7 with a hazard ratio of 0.78, and it was statistically significant in terms of progression-free survival. So what do we have? If we're looking at second-line therapy, we can combine any of these. We can go for capecitabine, trastuzumab, TDM1, capecitabine, lapatinib plus trastuzumab, everolimus, and vinorelbine. If you're looking at third-line therapy, then you've got capecitabine, lapatinib, the combination of anti-HER2 therapy, lapatinib and trastuzumab, as well as everolimus plus vinorelbine and trastuzumab. Looking at which gives you the best response rate, then you can see that TDM1 probably stands out in terms of overall response rate, as well as progression-free survival, as well as the overall survival, which is, as you can see here, this is second line and giving you 30 months in overall survival. Now, there's another question that you have to ask yourself. Do I fear for brain mets for this patient, or does this patient from the start have brain mets in terms of metastatic breast cancer? And if we want to look at which patients do we fear for brain mets. These are patients who are premenopausal, less than 50 years. They are ER negative, as well as having patients who have visceral metastasis. They are more likely to develop brain mets. And we can see from the EGF trial and the JBG trial, if we looked at this trial in terms of brain mets as site of first progression, we can tend to look at that trastuzumab combination with a capecitabine gave you more brain mets, 13.8 versus 2%, but this was tested out in one of the trials, the Cerebral trial. This was 540 patients divided by, or going on randomized to lapatinib plus capecitabine versus trastuzumab plus capecitabine. Site of brain mets or site of CNS as first progression, 12 versus 8 or 5% versus 3%, and this was not statistically significant. So can we prevent brain mets with the use of lapatinib? And the answer came from this trial, and probably it is no. Also, the Emilia trial looked at this, and this was presented in the last San Antonio, looking at the patients without CNS metastasis, looking at CNS metastasis as a site of first progression. If they did not have CNS metastasis to start off with, you can see it was 9 versus 3, or 1.8% versus 0.6%, and this was not statistically significant. And they had 95 patients who already had brain mets, and they, looking at the 45 patients were on the TDM1 arm, and 50 were on the capecitabine lapatinib arm. You can see that CNS as a progression, it was 10 versus 8, so not statistically in favor of lapatinib as would have been thought to. Progression-free survival was 5.9 versus 5.7 in terms of CNS mets, and the overall survival for patients who had CNS metastasis in this trial was 26.8 for the TDM1 versus 12.9 for the patients with lapatinib capecitabine. So even if your patient has had CNS metastasis and you have treated her with radiotherapy, then if you're going on for TDM1, I think it still would be a choice. But what we do know from several trials using lapatinib capecitabine in terms of brain mets and patients who do have brain mets, or you are treating them while they do have brain mets, whether if they've had prior radiotherapy, you get response rates from around 20% to around 30% if you're using the lapatinib capecitabine combination. And if your patient has not had prior radiotherapy, this is the last trial on this slide, as you can see, the last one, 45 patients here, no prior radiotherapy, you do get response rates of around 67%. Just using the lapatinib capecitabine combination, with a time to tumor progression ranging from around 4 months to around 5.5 months, so you can defer more further radiotherapy or decrease the progression for these patients. So if we wanted to wrap up all this, the preferred line definitely in first-line regimens would be the dual anti-HER2 inhibition with pertuzumab, trastuzumab, and taxane, unless the patient has toxicity concerns, whether it's cardiac or neurologic carrying out, because this combination was used with taxanes. Don't try and use it with something else. Patients with low burden tumor and who are hormone responsive, we can try an aromatase inhibitor plus an anti-HER2. Patients who do have brain mets, you have to be very careful with what you're giving. Probably lapatinib will still stand out in this setting. Second line is TDM1, then definitely gives you the highest progression-free survival. Other HER2 inhibitors, as Dr. Nuhad has said, will still continue to have a role depending on the toxicity profile of your patient and the availability of the drug at your institute rather than the efficacy. And thank you very much for your attention.
One or two questions, please. I think that your presentation was very clear, so all of us understood it.